Good afternoon, everybody. My name is Claire Coughlin and I'm the clinical lead for Bowel Cancer UK. And I'm delighted to be here this afternoon to introduce to you a webinar on genetics and colorectal cancer. This is a fantastic topic. We did a couple of these last year and they were really informative and I learned so much. So this afternoon, you'll learn about the current testing for colorectal cancer tumours, and how that influences treatment decisions, and how and when to refer for inherited conditions. Our speakers will introduce the topic properly, but just to say really that this is a field of practice that is ever evolving and exciting, and it's having real and positive impact on patient care. So I am delighted that we're bringing this webinar to you this afternoon. Now, I'm delighted. You may have heard both of them speak for us last year. If you haven't, do watch it back. They are both fantastic speakers with the most phenomenal knowledge in their areas. So Vicky Cuthill is our first speaker. Vicky is a nurse consultant in hereditary GI cancer syndromes at St Mark's Hospital. She started her nursing career in intensive care and then specialised firstly in benign colorectal conditions at the Royal London before moving into colorectal cancer at the Homerton, and then becoming a Polyposis nurse practitioner. Vicky's a nurse consultant now in hereditary GI syndromes at St Mark's Hospital, and works in cancer prevention work. She works with Macmillan Cancer Support to raise the profile of genomics in cancer care, and presents extensively on the subject and brilliantly. Laura, I've got to say her surname because I love saying it, Monje-Garcia, is the national lead nurse for Lynch syndrome, the Lynch syndrome project, and works at St Mark's Centre for Familial Intestinal Cancer. Laura's a nurse practitioner. She does fantastic work with Lynch syndrome. In addition to being a nurse, Laura is a health psychologist and has been working with patients living with inherited conditions since 2012. She started working with patients with rare dementias at UCLH and later with patients with inherited cardiac conditions at Imperial, and Guy's and St Thomas's and King's. So Laura started her work with patients living with inherited colorectal cancer syndromes in 2020 and started her own research project looking at the psychological impact of inherited colorectal cancer.
So welcome everybody. Laura and I are going to be doing a bit of a kind of moving between each. I'm going to start, Laura's going to do the middle section, and I'm going to do the end. So I think the main message we want to get across to you is that this can be a topic that's as complex as we want to make it, but actually if we want our patients to understand it, we need to simplify the topic, we need to demystify it, and we need us all to understand. And I think quite often the terminology can be quite confusing, but don't get bogged down in the details. So I'm going to give a quick update of some of the terminology, just as a reminder, because I know that most of you are becoming far more expert in this topic, which is brilliant. We're going to convince you all that cancer is a genetic condition, and therefore as bowel cancer nurse specialists, we need to know about this topic. I'm going to just touch upon the differences between sporadic and inherited cancer, so we've got that really distinction, because that's really important before Laura goes on to talk about the tumour testing and how important it is and how it influences the treatment decisions. We're going to obviously focus more on Lynch because it's the common inherited cancer predisposition syndrome, and I'll just can't get through a teaching session without mentioning the polyps right at the very end. So the first thing to say really is don't get bogged down by the terminology. You will hear these terms interchangeably: genomics, genetics. When should I be using them? Just think of genomics as the whole. Okay, a genome is the study of all our genetic information, and we're now referring much more to genomics in cancer care, and this is as we can do far more high throughput sequencing, testing large panels of genes, and therefore we're looking at multiple genes in one go, and it's more about the whole thing. Previously, prior to these next generation sequencing techniques, it was more about studying individual genes and looking at specific genes. But if you use the terms interchangeably, don't panic, it's absolutely fine. But genomics really is the term you will hear more and more. So just a bit of a recap before, so we know where we are before Laura starts talking about tumour testing. This is a very, very familiar picture for all of us. We all know and are aware of the double helical structure of DNA. It's tightly coiled. It sits within our chromosomes, which live within the nucleus of our cell. We know that some genetic material can sit outside the cell in mitochondria. That's a whole other teaching session. And when we refer to genes, we are referring to simply a section of DNA. And of course, we have 2 copies of each gene because we inherit one from one parent and one from our other parent. So let's look at the double helical structure a little bit more closely. And if we think of this ladder-like structure, you will see that the rungs, or you will hear them referred to as bases or nucleotides, they always pair in the same way, and there are only 4 bases. So actually, if you wanted to simplify this, you can say the genetic alphabet contains only 4 letters, and that is quite simple. And you will see them always pairing in the same way. And then if you can see by this picture, you can see if we cut the ladder in half and we look at the rungs from one side of the ladder only, we can see that these letters always form into words that are made up of 3 letters or 3 bases, and we call those codons. Now, codons pair in specific ways to form amino acids that go on to form proteins to make us who we are. And actually, if we think about it, you know, we're all different, we look different. There is an element of genetic change in all of us. So it doesn't always mean that an introduction of genetic change is a bad thing. It is only in specific circumstances that a genetic change may be introduced that actually causes disease. So, for example, on this picture, you can see that one of the bases, cytosine, has been replaced by another base, thymine. Now, in certain circumstances, different letters, different triplet codes or codons will actually form the same amino acid. So you could have a single nucleotide change and it make absolutely no difference. Sometimes you can have a very simple change and it changes the entire amino acid being produced. Now, if that change means that you truncate or shorten your protein, that can have really catastrophic effects. So there's lots of different ways of introducing change. Some don't matter, some can introduce disease. And it is really complicated. You can make it as complicated as you like, but there are very simple ways like this of looking at it. And many of you will have seen this slide before. I like it because I just think it beautifully describes why cancer is a disease of aging. We are born, and as we are exposed to UV, smoking, alcohol, and all those environmental factors, our DNA repair mechanisms decline as we age. So it's much more likely that we will pick up cancer-causing mutations as we age. Cancer is the disease of unchecked cell growth. And once cancer starts developing, it grows slightly out of control, and it's very clever. So we can give treatments like chemotherapy, and cancer can evolve, it can evade the mechanisms required to treat cancer, and it can mutate around that treatment, which is why often in advanced cancer, in metastatic cancer, what will happen is patients will become resistant to disease as the cancer mutates around that treatment. And that is why genetics and the knowledge of what is going on in that cancer is so important, to enable us to have real-time knowledge to give the right treatments to patients. And then if you take a step back and think about inherited disease, so if you look at mutations simply within a cancer, and it is a sporadic cancer, i.e. it has happened by chance, that is very different from looking at a cancer that has developed and is present due to mutation in each and every cell. So when that happens, you're already on the pathway to cancer when you are first born, if you like, and that means that often people with inherited disease will develop cancer at a much, much younger age. And I've already explained this slide, I'm ahead of myself there, but it is important to make the distinction between mutations that are just present within a cancer. Laura's going to talk a little bit more about that, and those that are present in every cell that predispose our patients to cancer. And that's why when we test a tumour, we want to tease out those patients that might have Lynch syndrome, for example, because that will have a big impact. So really important to make that distinction. Sometimes we will test a cancer and we will see more mutations than we would expect of a particular type, and we may then think, oh gosh, you know, this could be an inherited cancer, we need to do more testing, and Laura is going to talk to you about that. So hopefully I've convinced you all that due to the myriad of genetic change within cancer, it is a disease of the genome. We need to understand this topic, and there are different pathways to cancer at the molecular level. So knowing which pathway our patient is on is really, really important. But remember that the majority of bowel cancers that we see are mostly due to sporadic change as we age, and you can see that in the pie chart here. Of course, cancer is common. 1 in 2 of us is said to develop cancer. So many of us will know family members that have had cancer, and they may be familial links, but we cannot find a gene alteration. It is really a small percentage of patients where we see an inherited cause for their cancer. So it's kind of important to keep that in the back of our minds as well. And just to hone that down to bowel cancer itself, you can see here still the majority of sporadic cases. We've got these cases that we know there's familial links. We maybe look after families because we can see there's a large number of family members with cancer, but we haven't been able to pin down the gene alteration. And then lesser and lesser, you can see the majority are Lynch syndrome there, and lesser I've got to get those polyps in. There are then the less than 1% with FAP, and even less some of the rarer polyposis syndromes. So I'm now going to hand over to Laura, who's going to talk a little bit more about the nitty-gritty of tumour testing.
Thank you very much, Vicky, for the introduction. This is for everybody. So Vicky and I work together in the Tumour Center for Familial Intestinal Cancer, regardless of our job title and how they introduce ourselves. So now I'm going to go straight into tumor testing, because it's actually really important that you understand the information that the tumor testing actually provide. And going back to Vicky, thank you very much for clarifying that, you know, cancer is a genetic disease. Yes, it is. But the question is, where are those genetic alterations that have been accumulated and actually lead the cell to get out of control? Are they only in the cancer cells and they are isolated, or are they in the cancer cells and also in the rest of the cell, which means that they are inherited and they have a fall in some time of process that is gonna speed up that process of accumulation of genetic alteration that can lead to cancer. So that's why inherited colorectal cancers are really cancer predisposition syndromes. Not everybody will develop cancer, but the majority will, because it's, you know, the faulty system that they have that actually speed up that accumulation of genetic alteration that will cause cancer. So when people have tumor testing, it can be in different forms. You might get some very quick tests, and if you look at the bottom of the slide, you can see DNA, RNA, protein. So these tumor tests can come in different forms. Some they're going to be DNA, and you're going to see genetic mutations. Some of them they're going to be looking at proteins. Now, something very important to remember that Vicky has mentioned before: every gene will make a protein to do the job that they need to perform. So when they are looking at proteins, they're actually looking at the gene indirectly, but I will talk more about that. So really the tumor testing is what is going to get the information that it gives us is the characteristics of that cancer. What is causing that cancer? What is that process? And it also gives us not just one cause, but sometimes they give us a different genetic mutation of alteration that is actually drives the cancer. So I'm going to call them drivers, but basically it's the result from that tumor test. And why is it important? Most of the time is because it gives us some information that might direct us to target treatments that are going to work for that particular cancer. Because we know what is causing the cancer, we might find some treatments that actually work very well. Most of the time it's gonna give us information of treatments that they are not gonna work because there is no target treatment for that particular genetic mutation. So something to remember, it will be a target treatment or treatments, or it might direct us to treatments that they are not gonna work. And another very important piece of information, Also, some of these genetic alterations might give us information about how easy or difficult it's going to be to treat that cancer, the possible life expectancy of that patient, etc. So something to take into consideration. Lots of information, but if you remember that cancer is a genetic disease, this will make things much easier for you, and the type of information that they provide, and that is basically the characteristics of that cancer. This slide might be very familiar to you. So there is sometimes you get some information. Oh, okay, so this person have colon cancer on the right or on the left side, and you might get a slight idea of whether the cancer is going to be difficult to treat or not, or what treatment might be more effective. In fact, if you actually look at the tumor test results, that is really the information that you might want to find out more about. Like, for example, as you can see at the bottom, you can see that BRAF mutations are actually more common on the right side of the colon versus the left, and that probably explains, as I'm going to explain you before, why people who have tumors in the right side are actually more difficult to treat. But I'll tell you more about that in a minute. Now, at the moment, we're waiting about 21 days to get these tumor test results to give us those characteristics of the tumor that is going to help us to select the best treatment and to get an idea of the life expectancy of your patient and whether they're going to be responding to treatment. Now, recently, different specialists meet in the Royal College of Surgeons, and they're going to reduce the time that we are going to have to wait for these results. So you can see here in your left-hand side the name of genetic alterations that they're going to, or the genes that they're going to look for in this test, and they are aiming to provide a turnaround of those results within 14 days. Now, this will really help, because then you will have the information whenever you discuss the patient in your MDT. At the moment, most of the time, we know that you don't have this information, and it's actually very difficult to make the decision about what is the best treatment for your patient. And that's probably what you look at the right, left side and make a prediction as to what will be the best treatment for your patient. Maybe that will change in the future. Now, I'm going to start talking about somatic results. So we know that there is some genes that are being tested, and some of these genes are actually, they are not hereditary. I'm going to be talking about RAS and RAF kind of termination of genes. So these ones will never be hereditary. They happen very early at the start of the cancer, and they drive the cells to an uncontrolled growth in the body. And they normally work together in the EGFR RAS impact pathway. I'll tell you a little bit more about that, but let me show you a little example about that. I'm sure you have seen in the tumor test result, NRAS, KRAS, BRAF, they will never be hereditary. They are actually genetic mutations that are only present in the tumor, but they give us really important information about how that cancer works. So as you can see, the NRAS protein acts as an on and off switch to monitor the cell growth, division, and movement. KRAS actually is also an on and off switch that ensures the cells to grow and divide or mature and take a different function. And the BRAF protein stimulates the cell growth and division of the cell in response to bodily needs and the environmental cues. As you can see, I'm talking about the protein, but this is the protein that is produced by the gene. Now, what happens when that protein is not made properly? And I go back to when Vicky was explaining, what could happen if you have a genetic alteration that the protein might not be produced properly. So in NRAS, the proteins are locked on the on position, causing a constant and uncontrolled cell division. In KRAS, it's an oncogene because when mutation, it changes a normal cell, and it makes it become cancerous. And in BRAF is very similar, and basically it continues providing signals for the cell to grow, and it cannot be turned on. So that's how they cause cancer when the protein is not working properly, something to take into consideration. And why do we need to know if there is genetic alterations in these genes? Well, it's very simple, because we know that these are biological markers that is related to poor response to EGFR. So we don't know the best therapies. There is no target therapies, for example, for NRAS and KRAS. There is some trials for BRAF at a later stage, but we definitely know that we cannot give EGR treatments to these patients. Also, and in addition to that, for BRAF, we know that it's a prognostic biomarker for aggressive tumor growth. Now, this is a really important piece of information. We know that we need to provide this patient an aggressive treatment. And also we know that the life expectancy of this patient is going to be reduced. So something in addition to that to take into consideration. And I'm going to be talking about more about that in a minute. So these ones are actually, those were tests that we know they're somatic, or they are only in the cancer cells, and they are not hereditary. Now, there are some other tests that might give some indication as whether the cancer could be inherited, like, for example, the MMR test. So there is two different tests. You will be doing one depending on where you are. So your patients might be having microsatellite stability or MSI, or they might be having MMR immunochemistry. Now, do you remember when I was mentioning that some tests look at genetic mutation and some of them, they look at the expression of proteins? Now, immunochemistry is one of those tests that actually look at the expression of the protein. And we assume that if the protein is not working, then that the gene has been affected, and that's probably what it drives the cancer. I got a little picture in there that actually shows a normal immunochemistry under the microscope, and then the abnormal, that obviously they have less brown dots, that it shows that it's poor expression of that protein. The benefit of testing the protein is because generally you get the results back within few days. For immunochemistry, generally 3 days, which is really good, and that's probably why these tests are performed. Now, if your patient has what is called deficient MMR, then there is a chance that the person might have Lynch syndrome. This is a diagnostic pathway for Lynch syndrome. So every single patient with diagnosis of colorectal cancer, regardless of age or anything else, should have MMR testing, and the results will be available by the first time you discuss the patient in your NDT. Now, this is really important piece of information, because these patients will be eligible for immunotherapy, and I talk a little bit about that. Now, very important to note that anyone with the diagnosis of colorectal cancer under the age of 40 is eligible for genetic testing regardless. So if you have any patient under 40 or 40, please refer them to clinical genetics, or if you are trained for mainstreaming or you would like to be trained, get in touch. If you are trained for mainstreaming, you can actually offer genetic testing. Now, there is different patterns of loss. So if you have loss of any proteins that doesn't include the protein MLH1. MLH1 is the protein that you only need to remember. So let's say that there is loss of MSH2 alone. This patient is eligible for genetic testing for Lynch syndrome straight away, something very important to remember. Now, if there is loss of MLH1 or MLH1 plus any other protein, we need to do a further test. And why? Because obviously when we look at proteins, we are not sure if the gene is not working or not. We just know that the gene is not working. And there is an epigenetic process called methylation that actually switches genes on and off. And it's actually very common that cancer are actually caused by a hypermethylation process that actually switches the MLH1 gene off. Is only present in the tumor, is not present in every cell. If somebody has methylation in MLH1, then it's not Lynch syndrome, and that's in the majority of cases, about 75% of the cases. So those patients do not refer for genetic testing. Always wait for the methylation result if there is loss of MLH1. And again, if it's absent, to refer your patient for genetic testing for Lynch syndrome. So I'm just gonna very quickly talk about Lynch syndrome, because if you heard me before, you are probably quite tired of it, but Lynch syndrome is the most common cancer predisposition syndrome that predisposes to certain types of cancer. The main concern is colorectal cancer, and for women, endometrial and ovarian cancers. And there is also a very small chance that they might develop cancers of other types, like for example, urinary tract, gastric, small intestine, etc. But they are less frequent. If your patient has a diagnosis of Lynch syndrome, it's very important to take into consideration that even if you treat that cancer, that cancer in the colon might come back. So Lynch syndrome is caused by all these genes. So the MMR proteins that you were testing before with the MMR gene, plus another gene called FPAM that actually causes Lynch syndrome by inactivating the MSS2 gene. Here there is a little video. I don't know if it's gonna work, but basically it shows what Vicky actually told you before about this accumulation of genetic alteration in patients that have this deficient mismatch repair system. Oh, yeah.
When cells divide, their DNA is duplicated and separated into 2 daughter cells. Possible mistakes in the duplication process are usually detected and repaired by mismatch repair proteins in a mechanism called DNA mismatch repair, or MMR. In people with Lynch syndrome, this mechanism is deficient, so that errors persist in the DNA copies and accumulate, increasing the risk for cancer.
I hope that you found that helpful. It illustrates what Vicky was talking about at the beginning. So Lynch syndrome, what is important to know is that we can save the life of patients with Lynch syndrome and their family members if we identify them, because if someone has Lynch syndrome, their parents, siblings, and children will have a 50% chance of having the same genetic alteration. Another fact that is very important to know in Lynch syndrome is that cancer caused by Lynch syndrome, they are very treatable. The life expectancy is very good, especially if they receive immunotherapy. Now, I'm just gonna show you, if you look at the graph on the left-hand side, you can see in the dots in green is the patients that will have Lynch syndrome, MSI high and BRAF wild type or no BRAF mutation. And as you can see, generally patients have a really good life expectancy. Now, you remember when I was talking about BRAF, that they have very poor prognosis and the cancer is very aggressive. Another very good piece of information to know, you can see the straight red line. So they are not gonna do as well. This is just a graph. I'm gonna need to finish very soon because I need to hand over to my colleague, Vicky. But just to let you know that in green, you can see how effective is immunotherapy in patients with Lynch syndrome, with the Lynch syndrome associated deficient MMR. And if it's sporadic, it's not gonna work that well. If you go to the Macmillan website, it got really good definitions about what is immunotherapy, but basically immunotherapy is a kind of therapy that uses your own immune system to actually treat the cancer, which is extremely clever, and it has less side effect that traditional chemotherapy. Now, another reason why it's really important to identify people that might have Lynch syndrome is because we can do quite a lot to help them prevent cancer in the future. And if not prevent, then identify it and treat it early so the patient can have really good outcomes. As you can see, it's colonoscopy every 2 years, but then aspirin. Aspirin, a very cheap tablet of aspirin can reduce the risk of colorectal cancer or another cancer by up to 50%. And then obviously one of tested of H. pylori, lifestyle recommendation for women, prophylactic surgery, etc. Just very aware that otherwise I'm not giving my colleague Vicky any time to talk. Vicky, you can come back and carry on from here.
Thanks, Laura. I was going to say, don't worry, it's fascinating. So Lynch syndrome is the most common cancer predisposition syndrome. There are quite a few others that are extremely rare. So you may go through your whole career and never see any of these. So I'm not going to dwell on them too much if you're never going to see them. But I guess I will briefly mention FAP because it is the most common of the rare polyposis syndromes. Okay, and you can see some of the other conditions that some of you may or may not have seen and heard of. And Peutz-Jeghers, I always think Peutz-Jeghers is quite interesting because patients get quite distinct lip freckling, yeah, that condition just interests me quite a lot. But some of you may or may not have seen some of these. I will just point out right at the bottom there, serrated polyposis syndrome. Again, that's not an uncommon condition. If we've got any nurse endoscopists here, you will be seeing this more and more through probably the bowel screening programs, etc., etc. We tend to say that this can be managed in local departments because it isn't uncommon. We do not have a gene alteration for serrated polyposis, but that's probably, of all the conditions you're going to see, one of those that you may see more frequently. So let's just briefly mention, Laura's covered some of this. Why do we want to find people with Lynch? Why do we want to find people with inherited risk? Obviously, the main drive in the NHS at the moment is prevention and early diagnosis. So we don't want to see young people with bowel cancer. We want to skim those very, very high risk patients off the top. I don't want to see anybody in my practice with bowel cancer that we should and could have avoided in this year and any subsequent years. And there has been such dramatic change over the last couple of years with Laura's fantastic work and all the team from the National Lynch Programme, and we must maintain that change. If cancer's already developed, Laura has just beautifully explained that these patients come along a certain MSI high pathway and we can tailor treatments. So even if we don't detect Lynch, MSI high cancers, we can still tailor treatments, but if we detect Lynch, it's really important. They have a very, very good outcome. So we need to know. Family. Do I have to say that more? If we don't do this properly, we miss family members from getting tested. We miss early diagnosis or cancer prevention. And Laura's just beautifully explained that there are lots of things that we can do for patients who get diagnosed with Lynch or FAP or any of the other syndromes. It's not an automatic death sentence. There are ways that we can enable people to live long and healthy lives. So it's important that we pick out those high-risk people from those groups. So just briefly, because this is the one that you may have seen of the polyposis conditions, it's rare, the most common of the rare ones. Dominantly inherited, just like Lynch is dominantly inherited. What does that mean? You heard me earlier say we have 2 copies of each gene. A dominantly inherited condition means that we have 1 affected copy of those two genes, and that's really important to know and understand that, because if you're counseling somebody about whether or not they could have passed something on to their child with a dominant condition at the point of conception, you can either pass on your affected copy and therefore your child will have a condition, or you will pass on the unaffected copy and your child will be negative. So 50-50 for any child born to somebody who's got a dominantly inherited condition. Now, the main I guess the main point of FAP is bowel cancer. It's an almost 50% risk of bowel cancer by the age of 50 because they develop so many polyps and adenomas, and you only need 1 adenoma to get cancer, obviously, and these patients get sometimes thousands of large bowel polyps, but it is a multi-system disorder. So even when you remove the colon, that's not the end of the story. If you leave the rectum behind, you survey that. From the age of 25, we start surveying the stomach and duodenum. They can get extraintestinal manifestations like desmoid tumours. And so all I need you to remember from all of this is that their care must be specialised. You need to have a hospital with a good amount of these patients in order to provide the right care. And I've just linked some of the rarer syndromes there at the bottom as well. So I think the one thing I do want to advertise this afternoon is that there is now a rare disease collaborative network for patients with polyposis syndrome. It doesn't cover serrated polyposis. As I mentioned earlier, that's a fairly common condition that will be looked after in centres around the country, just like Lynch is. But please look at this list. This is where currently the centres are around the country that are looking after polyposis patients. So if you have polyposis patients and you are not on this list, you need to start thinking about repatriating your patients to one of these centres, and that is so the expertise can be maintained. Alternatively, if your patient can't travel to these expert centres, you must link in with these centres' MDTs so that you can make sure that you're providing consistent care for these patients. And why do we say this? Well, there is a UK rare disease strategy, and so you need to have a sufficient caseload, and this is for any rare disease, not just for polyposis. You have to have a sufficient caseload to build experience and expertise. You shouldn't rely on things like single clinicians. You've got to coordinate care. You've got to have a dedicated transition from paediatric to adult services. You've got to involve the families and have PPI groups, and you've got to have a decent amount of research. And you can't do that if you just look after one family, for example. And these are some of the principles that we look after our patients by. It's really nuanced, the type and timing of this preventative surgery. You think about all your patients that you look after that present with a cancer. How traumatic is it to find out that you suddenly are faced with having to have life-saving surgery? But at least you've got cancer, and it makes sense for most people, it makes sense to get rid of that colon or have a right hemi or whatever it is that you need, anterior section. It makes sense. You've got a cancer, you want it out. Imagine not having cancer, but being told your risk of cancer is nearly 100%. We're taking you in well, and we're whipping out that colon. You want to make sure that you've got the right operation for the right patient. And still today, nearly every single week, I see patients who are not or have not had the right level of care. You've got to have expert intestinal endoscopic surveillance. You've got to know what you're doing in terms of the extra intestinal management, and you've got to have a really good and robust system for cascade testing and surveillance. And of course, passing on patients who want diagnosis as well. So hopefully Laura and I have convinced you that genomics is used in all stages of cancer care for bowel cancer, from the beginning right to the end. And there's some really exciting developments with things like circulating tumour DNA, both in prevention of healthy volunteers to see if we can pick up cancer at a much earlier stage, and right at the end to see whether we can target surveillance better. I can imagine a future where we'll be doing regular blood tests, not even scanning, to see if patients have got early recurrences and preventing metastasis to some of the chemotherapy treatments. So do get in touch with us. I think these slides will be shared by the team. You can see our email addresses and everything there. And just to say a big shout out that our annual St. Mark's Conference Frontiers, which you can access online or face-to-face, so do sign up. It's dedicated this year to everything colorectal cancer. So please do sign up. There are some great speakers. Funnily enough, Laura is going to be speaking on there. So there you go. We've got an app for polyposis syndromes. We're hoping to get some stuff added for Lynch soon, and lots of information out there for everybody as well. I do love a TED Talk. I do love a podcast. There are lots and lots of different ways for you to access information. And of course, the Genomics Education Programme provides lots of free educational resources as well. And you haven't already done so, sign up, get in touch with Laura and sign up to her online modules for Lynch syndrome testing. It's definitely worthwhile. So thank you for listening, everybody, and please do ask any questions.
Thank you so much, both of you. As always, an absolutely fascinating talk, and I learned something new. Well, I learn a lot new every time I listen to you, to both of you, and I make loads of notes every time I listen to you. Thank you. So I've got a few questions for you, if that's okay. I know at the moment the aim is that everybody has MMR testing at the time of diagnosis. Do we have a sense of where we're at with that nationally? I know that's a big question.
So it's supposed to be going very, very, very well. Obviously, with immunochemistry, that is done really rapidly. Most of the places in the country, with the exception of one or two, they don't have to fill in any forms. So as soon as somebody gets diagnosed, the test is done. Now, immunochemistry is back within 7 days, more or less, I think, at the moment. But MSI takes longer because obviously the sample needs to be prepared. It needs to be sent to the GLH, and obviously they need to do the testing. So that might take us to 20 days. But it's getting better. Most places in the country, as far as we know, is doing it.
Okay, and there are plans, I think, to audit that in the future, aren't there? So we know exactly where we are.
Yeah, so obviously at the moment, we are asking people the Lynch champions within each colorectal and endometrial cancer MDT to complete audits. I will be really grateful if somebody hasn't done it to do it now and to send it to your regional Lynch syndrome nurse. But there is also the NDRA's database of cancer stats, so that is actually catching up. So we got data from 2019 and 2020 now, and that is slowly catching up. And the plan or the idea is that in the future, there will be a real-time data that people can look at. Now, is that possible? Well, that is very difficult, but you know, people will have something to look at perhaps in the future if, you know, it relies quite a lot on people sending data centrally so they can input this data into the NDRA's database. So that's one of the issues.
Thank you. And so just to be really clear, if there's anyone watching this webinar that's interested in becoming a Lynch champion, or whose MDT doesn't have a Lynch champion, and they're thinking, what's one of those? I don't know. What do they need to do?
So if they would like to be a Lynch champion, so the first of all, as in your NDT, maybe there is a nominated Lynch champion that is actually not doing the role, but maybe because they don't have time, etc. Or even if they are doing what they are supposed to be doing, it's really nice to work in a group. So ideally, you know, a really good team will be a nurse, a consultant, and histopathology working together as a Lynch champions, with one person having the main responsibility. And their role is actually to audit their diagnostic pathway for Lynch syndrome, from tumor testing all the way to germline genetic testing or referral for germline genetic testing, and see how it works within each NDT. And when they do the audit, they can get help through the regional Lynch syndrome nurse to actually work out in ways in which they can make the pathway automatic and to make it work for everyone. So you got more time to look after your patient rather than looking at audits and you know, chasing information. So that's the kind of role that they will be doing. And if anybody's interested, please contact your regional Lynch syndrome nurse or contact me and I find out who it is.
And just to say that all those fantastic links for information that you put on that last slide, we will email to everybody that's registered today. So we've got a couple of quick clinical questions coming now. So one is, until what age do we do 2 yearly colonoscopy for Lynch syndrome patients? Is it until they reach the age that they're eligible to join bowel cancer screening?
Yeah, actually, we didn't mention the bowel cancer screening program, didn't we?
No.
Laura? Because it's very, very exciting. I don't know how I could hold myself in from the excitement. But last week, the screening program launched, you know, the Lynch patients. It's not been done with huge fanfare yet, because obviously the teams around the country need to work out and make sure they've got their processes in place. But that means that essentially you diagnose somebody with Lynch now, you add them to the Lynch syndrome portal, and then they're on the bowel cancer screening program, which is just amazing, because it means that people will get their colonoscopy on time every 2 years until the age of 75. And then I think, I'm presuming, although it's a little bit sketchy, I'm presuming they can opt in, can they, Laura, if they want?
They can opt in now. So basically it's up to the patient. So if the patient is fit, so it's the usual, Vicky. So if the patient is fit, they can contact the now bowel cancer screening program and tell them, actually, I would like to continue having 2 yearly colonoscopy, which is absolutely fine. Just one little note about that. You don't need to register patients for the National Bowel Cancer Screening Program. That's done by clinical genetics or specialized centers like St. Mark's. So as soon as the patient have germline genetic testing, the clinical genetics will do it. Or if you are mainstreaming, as soon as you refer them, it's really important that you refer them so they can register. And unfortunately, not everybody can do it. Otherwise, they will become overwhelmed. The same person will be entered multiple times. So that is just to avoid that.
And thank you. And presumably there'll be a bit of a time lag between everybody being put onto that. So the patients that we know have Lynch syndrome already under our care. So we just need to be sort of vigilant while it moves over, I'm thinking.
Yeah, I mean, if it's somebody with cancer and it's been recently diagnosed, they're going to have a colonoscopy 1 year after as part of their cancer diagnostic pathway. So that is actually really safe. So hopefully within 1 year, then they will be called out. But it's really good to still refer and to still keep that 1 year or maybe 3 years as well. Most of patients also have it 3 years after. This is just in case someone gets picked up 1 year later and they already have like 1 year follow-up cancer diagnosis colonoscopy. So just to keep it the way it is, and if they need to cancel, let the bowel cancer screening program do it.
Yeah, thank you. Okay, there's another question. So I'm sure you've mentioned it. It says, but when should we start upper GI screening for FAP, and how often should we do OGDs for this patient cohort, please? And thank you for your brilliant presentation.
Oh, thank you. So yeah, OGD 25, please don't do it earlier. These people have got to have their scopes for the whole of their lives. I see children being scoped. You know, don't do it. 25, unless somebody's got a symptom that you're worried about, like anybody off the street who's got a symptom. And then this is where you need to know about FAP, because there's a whole surveillance Spiegelman staging system, and you need to know the size of the polyps, the histology, where they're located, and there's on the app, for example, there's a screening tool. You put the details in and it gives you a stage. So it's 1, 3 or 5 yearly, depending on the stage of that duodenum. And then if you've got an enlarged ampulla, for example, that's over 1 centimetre in size, that's dealt with separately, that's annual. But I guess what I'm trying to say is you need some in-depth knowledge really to know about this. And that's the other thing I get. I get patients coming to me frightened of having OGDs because endoscopists haven't understood that these patients need heavy sedation because this is traumatic and they need them regularly. We don't want to put people off having an OGD because they've got to have them for life. And you need to know how to stage that stomach, that duodenum, that ampulla effectively to tell you what's changing. So that's why we say get those patients to one of the specialist centres that I talked about, or at the very least, if your patient wants to stay with you, that's great, but link in with your specialist service and make sure the complex cases are put through an MDT. And that's to protect the team just as much as the patient, because if something goes wrong and you have not been linking in with your MDT, you know, that is I would say that's quite high risk care that's being provided.
Yeah, that's excellent advice, actually, because you do sometimes have families who want to stay and have their screening locally, but to still be able to access that specialist MDT support. That's really good advice. Thank you. I've got another clinical question, and it's about when somebody's been diagnosed with Lynch syndrome and had a colorectal cancer and is now thinking about family planning and fertility issues, where are we best advised to refer those patients, or ask the patient's GPs to refer them?
Clinical genetics is the best place for a family planning consultation. So there is obviously you know about pre-implantation genetic testing, it's called now. So if they don't have any children in the past and it's the first child and they meet the right criteria, they're under, you know, the female is under 40, they don't smoke, they're in the right way. So there is a very, you know, strict eligibility criteria. They will be able to access this, what we call IVF plus treatment, but it's basically an IVF treatment in which they test the embryos and they make sure that the implanted embryo hasn't got Lynch syndrome. But, you know, there is a very strict eligibility criteria. Vicky, would you like to add anything to that?
Yeah, I was just going to,
very strict.
I was just going to say that I quite often, I don't get involved in eligibility criteria because I find it's difficult to say to patients, you know, who there are stricter eligibility, and I will say to patients, look, there are eligibility criteria, but what I'm going to do is ask your GP to refer you to your local genetic service so they can discuss this with you in depth. Do you know what I mean? We don't have, generally, most of us will not have time. We're not up to speed with the criteria. It changes a lot. And that's what your geneticists and your clinical genetic counselors are trained for, to have those fairly difficult conversations with people and to make sure that they're the right candidates, if you like. Whether I agree with the eligibility criteria is neither here nor there, because if you think about the expense, I think that's the simplest thing to do, is just make sure that they're referred by their GP to their local services.
In any
so
way,
it's not, sorry, I was just going to say, so it's not that we would refer to in the normal way as people would be referred for fertility issues for IVF. You should do it through clinical genetics. Yes.
Yeah.
Okay.
Yeah, and I suppose, Vicky, you know, going on on this conversation. If they are not eligible, they will be able to discuss other options with them. So it will still be really useful, because there are many other options and they are specialized to actually have this conversation. Thank you, Vicky.
Yeah, it's just about getting the patients the right advice from the right people, isn't it?
Yeah.
Okay, that's brilliant. Well, thank you both so much. As always, the most fantastic, informative talk. I, for one, will watch it back, as I always do, and take even more notes to try and improve my own knowledge. But thank you. Now, just some information about that we would like you to share with your patients. So we've launched a family, friends and carers hub on our website. It's a library of information, had lots of input from patients about what they would find helpful to go on here. So we've got lots of information in the same place. So please do signpost your patients to it and go on and have a look yourself. It's really very, very useful. We've updated our Eating Well booklet. Patients and health professionals have inputted into that. It's a fantastic publication and really helpful, and we get loads of great feedback about it. So if you haven't got them already, you can order in bulk for yourselves, or your patients can go online and order them individually if they would like to, if that's preferable. Just to say, if you don't know about this, we have an Ask the Nurse service. Please signpost your patients to this service. We now have 3 nurses working on this service, and they're all fantastic. They're really good specialist nurses. And what they give is advice that isn't specific clinical advice, but they help with signposting and supporting patients. They're very careful in how they answer queries, so that they don't give clinical advice because you don't have the full information, but it's probably one of our best evaluated services. Patients find it really, really helpful. So please do signpost your patients to use that. It's an email service. And then finally, our online communities forum. This is a really welcoming place, lots of different topics. Basically, it's patients sharing and supporting each other. There are moderators on each forum. There are all sorts of topics that people can join, and they're moderated to make sure that what's said on there is appropriate. And they're really useful. And the other thing, we have a specific Facebook group, so Living with Stage 4, caregiver help and support, and immunotherapy support, and I think there's a pelvic exenteration Facebook group as well. So do go onto our website and have a look for those. Thank you so much for joining us this afternoon. We really appreciate you giving up your time. We hope it's been useful, and we look forward to seeing you all at our next education event. Thank you very much.